What is going on, everybody? It's been a minute. Haven't seen you guys in a little bit. I was on vacation all of last week. Went through the polar vortex in New York, East Coast. I survived. Had to buy all new winter clothes to do it, but I made it. Now let's get back to the live sessions. First of all, enough about me. How have you guys been? Everybody's been chilling, getting stuff done, staying motivated. All right, good. So, the last couple of days, yesterday's case of the day. By the way, I am repping my internal medicine intern year fleece, right there, baby. This is like 5 years old now. So, what were we talking about? Oh yeah, so case of the day, NYC. There you go. Case of the day. Yesterday's case of the day. I said, is this chest X-ray normal? The majority of you guys, I think it was like 80-something%, basically said no, it was not normal. I don't know how I worded it, whatever I did, something stupid, right? I'm making up a number. 82% said it wasn't normal, and then I said why. And then that's where there's a lot of deviation as to, okay, I don't know why the chest X-ray isn't normal, but something was abnormal about it. Number one, I wanted to reiterate my search pattern and make sure you guys remember your search pattern when you're looking at chest X-rays and what you should be looking for, all the lines and angles. If you don't know what I'm talking about when I say lines and angles, go to my YouTube page. Link is in my bio. Go to the thing that literally says you can't miss this or don't miss this, something like that, right? Go look at that chest X-ray lecture. It literally covers everything you need to know about chest X-rays when you're rounding on the wards, rounding on patients, surgery, medicine, whatever specialty. So look at all your lines and angles. So that's what I wanted you to do on this last case yesterday, which is this one, just to reiterate what was posted yesterday. All right, so lines and angles and symmetry, right? Because 90-something% of your body is symmetric. So just start going from left to right in the lungs, keep going, and then all of a sudden you're going to start seeing some stuff that is not symmetric. So for example, I'm looking at this area, what's going on here, and I don't see it on this side here. So already something's up, all right? So something's going on, I don't like it, so I'm going to start focusing on this area, but I'm not going to neglect everything else. I'm going to start looking at my angles here, all my lines here. If I windowed it better, you could see the cardiophrenic angle right there. I'm going to start looking at this hemidiaphragm, and I'm going to look at the angle here. So I'm going to look at absolutely everything, okay? By the way, does anybody know what this is called when the hemidiaphragm isn't like nice and smooth like that? It kind of looks like it has a bump here and then another bump there. Does anybody know what that's called? Give you a couple of seconds to type it up. So you have eventration of the hemidiaphragm. It's just a weird hemidiaphragm that's kind of like lobulated, that kind of stuff. No biggie. Anyway, so we looked at the rest of the chest X-ray. We focused on this area, and we said, yo, something's going on here. This doesn't look normal to me. I don't like it. And then the very last part of what I do on my search pattern is look at the bones. I look at the clavicles. I look at the AC joints here, I look at everything else, and then I start looking at the ribs. And I notice that, yes, these are fractured. Let's go to the next page here. I zoomed it up. You can see it. Here's a zoomed in version of it. You see the fractures. So, I mean, they're acutely displaced. They are basically separated from each other. So he does have fractures. And let's go back to this one here. So he does have fractures, and he has this right here. So the question is this an acute fracture or is this a remote fracture? This happened weeks ago, whatever it was. So when fractures heal, it doesn't matter where they are in the body. It could be your tibia, it could be your fibula, ribs, whatever it is. When fractures, bone heals, osteoblasts go and make new bone. So the bone is going to get sclerotic, it's going to get dense, and it's going to get a nice callus formation around the fracture site. I don't see any of that here. I see an acutely displaced fracture that it's just split wide open. There's no callus formation around it. There's no sclerosis around the fracture site here at all. That's just an acute fracture, okay? One thing that I want to stress upon you, especially any radiology residents that are listening right now, is if somebody has, it gets like a rib series or a chest x-ray and they're complaining of, yo, I think this patient has an acute fracture of the rib, can you tell me? So I'm going to look at it and I'm going to say, hey, you know what? There's no acutely displaced rib fractures. There can be non-displaced rib fractures, which are going to be very tough to see on a radiograph. Sometimes they're even tough to see on a CT scan. Then what do? Usually we recommend, hey, get follow-up radiographs 7 to 10 days if we're talking about an arm, if we're talking about a leg. But if we're talking about ribs, you actually want repeat radiographs in 4 to 6 weeks or in weeks down the line. It's not just 7 to 10 days like a normal fracture. These things take longer to heal up, longer for you to see that callus formation. All right, now this stemmed into this whole other discussion. People were wondering, what is that thing? What is that thing around that fracture site? What is this? Why is this little bulbous opacity right next to the fracture site? A couple of things that I want you to take note. You can see this border of it, right? The medial border, you can see it. Can you tell me where the lateral border of that is? You cannot. You can't tell me where this thing ends and where the skin starts. You can't tell me that, right? But you can tell me on this side, hey, it ends right here. There's a distinct line. This is what I want you to start noticing for pleural-based stuff. Lesions, whether it's a mass, whether it's fluid, whatever it is. If it's pleural-based, you're going to see this basically one edge of it, but you won't see the other edge of it. So I have something pleural-based right here next to a fracture. Let's go. Occam's razor. If somebody has an acute fracture, a rib fracture, any sort of fracture, you're probably going to have blood nearby, right? So that's why I call this a hemothorax. This is concerning for a hemothorax. So somebody has a fracture, if it's a rib fracture in this case, and he has loculated fluid right next to it, that's a hemothorax. Now let's go over terminology real quick, all right? So somebody just typed up right here pneumothorax, and I got a lot of pneumothorax yesterday too. What is a pneumothorax? A pneumothorax is air where it shouldn't be, in the pleural space, right? So you have abnormal air in the pleural space. What is a pleural effusion? That's simple fluid in, or it could be not simple fluid, but that's effusion is fluid between the lung and the chest cavity. So pneumothorax is air between the lung and chest cavity. Pleural effusion is fluid between the lung and chest cavity. Hemothorax is blood between the lung and chest cavity wall. Now, you can kind of mix and match terms too. If I said a hydropneumothorax, means there's fluid and air between those two areas. If I said, hemopneumothorax, that's blood and air between the lung and chest wall cavity. So you can kind of mix and match these words. But once again, this guy has an acute fracture. He had some sort of trauma. Anybody who breaks a bone, I'm sure there's going to be blood nearby, right? That's why I call this a hemothorax, okay? I didn't see a line, a pleural visceral line. Some people, and I'm going to address this too because this is a fake out. Did some people look at this line right here? Do you see this line right here? And did you start questioning a pneumothorax? Okay, if you go back to one of my other lectures, I talked about how you look for a pneumothorax. Yes, you see the line, but I also mentioned before that people's skin folds can give you this weird fake out and it will look like a pneumothorax. But what did we say? When you see a pneumothorax, you will not see vasculature or vessels going beyond that line. Because what is that line? That's the freaking edge of the lung, right? So if you had the edge of the lung, why the hell would there be vessels going past that? Okay, so take a look here. You see this line, but look, I can convince you that there's a line right here, like a vessel. There's vessel. Even this vessel, this is a perfect example. I can't even see if it's projecting well. Okay, I'm looking at the camera and this at the same time. Here's the line, right, that somebody got faked out for a pneumothorax. Look at this vessel. It's literally crossing that and going to the other side. So how could you have a pneumothorax with vasculature going beyond the quote-unquote pneumothorax line or the edge of the lung? You can't. So that was not a pneumothorax, okay? So I want to dispel that question that I had multiple questions about it yesterday. So once again, just to reiterate for anybody joining, this guy had acutely displaced rib fractures. Okay, there's no callus formation. There's no signs of healing. This is fresh. It just happened. And then you have this pleural-based opacity that you really can't see all the edges of it, and it's right next to the fractures. So you should need to start immediately thinking about a hemothorax underlying those rib fractures. Now you can ask, how can you definitively tell that this is a hemothorax? One, you can stick a needle in it and figure it out, but why would you do that, right? You just get a CT scan, and you look at the CT scan and you compare what the fluid density looks like. If you want to do it visually and you think you're a superstar and you're looking at it and you're like, well, this doesn't look the same as simple fluid. Once again, if you've heard me talk about before, where is simple fluid found? 3 things. This is just like MRI T2 sequence. Go look at the gallbladder, go look at the actual bladder, or if you can see the spinal canal for some reason, you can see the fluid around it, compare those 3 things. It's better compared on MRI, but you can kind of use this for CT as well. If you look at the gallbladder and you see this fluid looks the same as a gallbladder, okay, maybe it's simple fluid. But if you have an issue and you're like, I don't know, this may be simple, this may not be, something called the Hounsfield units, okay? Hounsfield units, if you know how to use this on your PACS machine on your computer at work, basically it's a calibrated number and it's based upon simple fluid, okay? Simple fluid, for anybody who's really wants to get into the technicalities, it's generally around -20. It can go up to about as high as 20. I'm still okay with that. So -20 to 20, that's simple fluid. If I'm getting above 20, 50, 60, all right, I'm starting thinking about blood, okay? If you're talking about air and everything, that's way different. Bones way up there, air's way down there. Don't worry about any of that stuff, okay? So for this specific case, if I put a Hounsfield unit on the CT scan and I saw that it's -20 to 20, I'm okay. I'm thinking this is maybe just a simple pleural effusion. If it's up there 50, 60, I'm like, all right, you know what, hold on. This is probably blood products, especially given that there's underlying rib fractures, all right? Then somebody asked me and I posted, somebody asked, how can you tell the difference between hemothorax, pneumothorax? So we covered those 2 things, right? Just to reiterate, pneumothorax is air between the lung, the edge of the lung, and the chest wall cavity. There's air in that space where there shouldn't be. I've talked about this before too. How can you tell if the pneumothorax has tension, if it's a tension pneumothorax, right? The 3 things that I love talking about. 1, look for the mediastinal shift away from the pneumothorax. There's so much air getting pumped into that pleural space that is shifting the whole mediastinum to the other side. Look at the tracheal deviation. Look at all that stuff. Look at the hemidiaphragm. What's going to happen if you have a bunch of air being pumped into there? Well, the hemidiaphragm is going to flatten out, right? Because the air needs to go somewhere, so it's going to try to escape. Therefore, it's going to end up pushing down on the hemidiaphragm. It's going to shift the midline that way. And then the number 3 thing that not a lot of people like to look for, you look for the ribs on that side. They're going to actually widen out compared to the other side, because remember, everything's symmetric. We got 2 sides. So look at the ribs on that side that you think is under tension. They may actually be spread out more than usual, again, because the air is trying to escape somewhere. So that's a tension pneumothorax, okay? That's a pneumothorax. We talked about the pleural visceral line, and we talked about how the vasculature, you should not see it crossing that suspected pleural visceral line. Once again, this is not a pneumothorax. I see vessels going beyond that line. Skin folds can do this all the time. And you may think skin folds, you'll see a lot on these obese patients, but no, man, they have a lot of fat. They stretch out their skin. It's a lot of these cachectic patients that have just loose, floppy skin that will kind of fold up on itself, and a skin fold can cause the appearance of a pneumothorax. Remember that, all right? That's just me personally. What I notice, a lot of these skinny cachectic patients have a lot of skin folds. If you want to figure out if it really is a skin fold or not, I've gotten faked out many times. Just ask them to get another chest x-ray. They're going to get another one. There's no way that the skin is going to fold in just the same exact way than it was on the prior chest x-ray. It's not going to happen. All right, and then we talked about pleural effusion briefly. We talked about how that can look, how to confirm on a CT scan. And then somebody asked about atelectasis. What is atelectasis, right? It's a fancy word. You hear that put down on all these chest radiograph reports. I say it all the time. Somebody's got atelectasis in the bibasilar regions, small pleural effusions, blah, 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 right? What does that actually mean? I want you to think about lobar or lung collapse. Just think about lung collapse, and then we're going to work our way down. So you think about the whole lung is whited out. Please, 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 I've asked this question so many times. If you have a complete lung whiteout on one side and it's due to lung collapse, which way is the trachea going to go? Towards the collapse or away from the collapse? And a large pleural effusion will be the exact opposite. Please tell me you get that right. I swear I will ask this question again. I want 100% everybody to get it right. Start answering that, please. All right, anyway. We're talking about complete lung collapse will be all the way up here, which is basically, think about an endobronchial lesion. These are fancy words. What does endobronchial lesion mean? Basically, there's some sort of something. If maybe it's a mucus ball, a big old mucus ball, but actually maybe it's cancer, right? So maybe there's an endobronchial lesion stuck inside the main bronchus. How is air going to go back and forth there? It's absolutely not. Imagine you have a garden hose and I just somehow shoved a ping pong ball in the garden hose. I don't know how, but yeah, I did it, right? There's no way that water is going to go back and forth. In this case, no way air is going to go back and forth. So what's going to happen? That whole lung is just going to completely collapse down. You're going to get a completely whited out lung. I already saw some people said the trachea is going to shift towards the collapse, absolutely towards the same side. If it's a large pleural effusion, the trachea is going to go the other way, okay? So remember that. So lung collapse, endobronchial lesion, something is causing the whole lung to collapse down. All right, what else? So that's internal, basically the air is not going back and forth, right? That's some sort of internal process. Well, what else can cause a completely whited out lung instead of collapse, right? You can have a large pleural effusion and that can actually just kind of squish down the lung. That can happen too, right? Well, now let's scale that down. If I'm talking about the whole lung, now let's scale it down to a smaller area, okay? Forget about the whole lung now. Now just think about a tiny little segmental portion of the lung. Same thing. I'm not talking about a huge endobronchial lesion now. I'm talking about a little tiny bronchus, bronchiole, something small that's going to get plugged up. Mucus plugging, aspiration, just the patient not taking a big deep breath. I've showed you radiographs in the past. What happens when you have hypoventilatory changes when the patient basically just did not take a big deep breath in, right? I take a big deep breath in, my chest cavity goes out, I suck in all this air, and it gives this nice, beautiful chest x-ray. But what happens to these patients who are like post-op, they're sitting in bed, they're in supine position, 4 days, 5 days, 6 days, whatever it is. Couple of things that are just slam dunk. You're just going to see this all the time on these post-op patients. Number one, atelectasis. They're not taking big, deep breaths in at all. Number two, we're always checking for the ileus in the abdomen. They have these post-op ileus, right? Just dilated bowel loops. Those are the two main things that I notice on all these post-op patients. You may wonder this. You may be a med student, resident, intern who's just starting. What are these stupid little things that they give these patients post-op? They ask them to take these big, deep breaths in, and this little ball goes up and down, and they keep asking them to do that over and over 5-6 times a day. I wrote orders for it when I was an intern all the time, right? Incentive spirometry. You kind of ask the patient, they purse their lips around this little mouthpiece, they take a big deep breath in, ball goes up, and then they try to keep getting that ball higher and higher. The whole purpose of that is not a fun little game that to kind of keep the patient occupied in bed, right? The whole purpose of that is you're trying to get the lungs to kind of inspire as much as possible, get them nice and big, and they want to open up that atelectasis, okay? So atelectasis is the scaled down version of a complete lung collapse. So when you think about this huge complete lung collapse, you're thinking the lung is completely squished down. Atelectasis is just a tiny little portion of it squished down. There's different types of atelectasis too. The main one that I want you to worry about, don't worry about all the fancy atelectasis. I don't want to get into the nitty gritty of how can you tell it's 100% atelectasis versus a little bit of pneumonia in the lung bases? Because you know what? Honestly, that is hard to do. That is something that you just have to see thousands and thousands of plain films, and still sometimes you won't know. And sometimes you look at the clinical chart and you say, hey, you know what? He's febrile, he's got a white count. You may have to go with it. Other times, I'm to the point where I dictate, hey, atelectasis, or maybe, you know what? There's just some opacities in the lung bases. The clinicians know. They know if the patient feels like they have, pneumonia, they're coughing and doing all that stuff, whatever, right? So the one atelectasis that I want you to get used to seeing, it's a slam dunk atelectasis. Once you see this, you know it's atelectasis, is this one right here. This guy right here, linear atelectasis, discoid atelectasis, plate-like atelectasis, whatever you want to call it, that's what this is. you will not really see a pneumonia that makes this nice little line like that, nice little line like that. No, you don't see that. This is plate-like discoid, again, however you want to call it, linear atelectasis, okay? So, Pete's waving hi. What's up, buddy? Okay, so that's discoid atelectasis, all right? The other atelectasis the reason I want to stress this atelectasis because this is a common opacity seen on CT and radiographs that people will say, I want a biopsy. Me, biopsying a lot of lung lesions, I get consults for this quite often, and they say, I mean, every once in a while, not quite often, and they say, I want a biopsy of this. This is called round atelectasis, okay? Round atelectasis can be very scary. It can look like this round freaking Goomba just sitting there, right? And you're like, oh, I don't know. This is something scary. Is it cancer? Is it pneumonia? I don't know what this is. And it doesn't go away. Why do we always say when somebody has pneumonia and we're looking at the radiographs, we're like, all right, get a repeat chest radiograph and, whenever the patient's done with their antibiotics in a couple of months. Because, I love going on tangents. All right. So somebody has pneumonia. I diagnose pneumonia on chest radiograph. And I say, this is pneumonia. Start them on treatment. They start them on treatment. They send the patient home. Whatever the treatment is, I don't know. You guys know more than I do, right? You get a Z-Pak. You get a Cipro, whatever it is. They go home, they finish that, and then they bring the patient back outpatient, and they're like, all right, here's a repeat chest radiograph in 2 months. Hey, it looks like everything cleared up. You're good to go. See you, buddy. What if, though, that didn't clear up? First of all, then their treatment was inappropriate. So maybe it wasn't bacterial. Maybe it was fungal. Maybe it was something else. It wasn't appropriate. Maybe they changed the regimen, and then they got a repeat chest radiograph again, and it was still there. Then you're like, oh, shoot, something's going on. It's been 5 months that this opacity is still there. Maybe it's not pneumonia. Maybe it's cancer. That's why we always stress these repeat radiographs that maybe cancer is hiding down under there, or the treatment wasn't appropriate. They need to switch their antibiotics, maybe antifungals, whatever it may be. Where I live, coccidioidomycosis, really prevalent. If you're in the East Coast, histoblasto, that kind of stuff. TB, always, right? So you got to kind of figure it out and tailor it. That was my tangent. Round atelectasis, that's how I got there. So round atelectasis is basically 3 things that you need to look for. I wish I had a case, but I will show you a case, I promise. I'll post it on my stories maybe tomorrow, soon. I'll make it a case because you guys may forget about it, and then I'll put it on there. But if you're listening right now, round atelectasis has 3 things that you need to be looking for. First of all, 1, there's a loss of volume on that side. And that makes sense, right? It's atelectasis. There's loss of volume, okay? Number 2, there's a tiny little pleural effusion next to it. And then number 3, it kind of, the way I describe it, go Google right now, a jellyfish. The jellyfish, it looks like that, and it has the tentacles going around that's what round atelectasis looks like. So if it looks like there's a jellyfish, there's loss of volume on that side of the lung, and there's a tiny little pleural effusion, that's round atelectasis. Don't biopsy that. Don't put a needle in it, please. Okay, I need to drink water. What else? Trapped lung. Let's talk about that. This is everybody's favorite. This will scare you. This will absolutely scare you when you're an intern and you're doing a thoracentesis on somebody. Somebody came in, they have this chronic pleural effusion. It's been sitting there. You have documentation of, 5-6 months of pleural effusion. You're finally like, all right, I'm gonna tap this. I'm gonna get this fluid out. I'm gonna get this patient, feeling a lot better. You do the tap. You did it under ultrasound. You feel like you absolutely aced that thoracentesis. You get their chest X-ray afterwards. Yeah, the fluid's gone, but now you have this huge area of just air. You don't see lung at all, and you're like, shoot, I just gave this guy a pneumothorax. But you're like, well, he's kind of asymptomatic. He doesn't feel like he's, short of breath or anything like that. His vitals are completely stable. He's not tachycardic. He's not hypotensive. It looks pretty good. Are you going to consult me and say put a chest tube in that? No, because I'm going to tell you this is what a trapped lung is, okay? So when somebody has this chronic pleural effusion, it's usually some sort of inflammatory effusion. Sure, it can happen with these hepatic hydrothoraces when there's just massive ascites that has gone now up into the pleural space. It's just always is causing compression of that lung. So anything with this chronic effusion is going to cause this lung to sit down and collapse on itself. So instead of being that big, it's going to chronically now be that big. And the patient has compensated over time because it's just been happening forever. He's just getting air through that little tiny area. He's compensated well. He's no problem. But when you suck all that fluid out there, this much of fluid, now what's going to occupy this space is just air. That lung will not re-expand immediately. Absolutely not. Sometimes it just doesn't re-expand. If I put a chest tube in there and I try to suck out all the air, it probably won't either. It turns into kind of like a fibrotic film around that area that just stops the lung from re-expanding. So that's a trapped lung. Remember now, if you're an intern, you're doing a thoracentesis, and you're like, oh, you know what? Hey, I think I just gave this guy a pneumo. Just be wary of that, hey, this may be a trapped lung. Remember that. All right. Was there anything else on these chest radiographs? I don't think so. Anybody have any questions? Did I miss anything up here? Father's a pediatrician and gets a lot of pneumonia. Yeah, peds patients. If you have a pediatric patient, I believe the guidelines are around 8 years old now. So if you have, welcome back. Thanks, buddy. Appreciate it. It's been a while. So if you have a peds patient who's less than 8 years old and you see this round opacity on a chest radiograph, don't be worried about cancer. It's round pneumonia. Treat them, move on. That's it. What's your YouTube page? Hey, nice segue into me telling you that, guess what? Go to my bio page and there's two little fingers pointing down. It says YouTube. Go check it out. If you don't want to look at any of the other stuff on my YouTube page, I'm doing this for you guys. If you don't want to do it, that's totally cool with me. But go look at the chest radiograph one that says you can't miss this. Do it. I eventually will do this for all modalities, all different things. Head CT, just a normal non-con head CT. For CT abdomen, I'm gonna do everything live, just like how I did on that chest radiograph one. So go do that. Thanks for asking that question so I could segue to that. Thanks so much for this. Hey, thank you guys for tuning in. I appreciate it. Seriously, it feels good to be back doing this. It was only, it was like a whole week. What up? Anybody else? Was anybody else in the polar vortex out on the East Coast with me? While I scroll up and figure out if I missed anything. All right, next thing I am... Pete, look at that. That's a buddy right there. Don't listen to him. Go follow, like, and subscribe. I like that. I appreciate that, man. I'm going to do a lot of collabs with different specialties. I already got them lined up. So tomorrow, Pete, man, you do my best shouting out right now. I can't say any more than that. Thank you, man. No, I'm doing a lot of collabs. So hopefully tomorrow, I got to see if he's available. Cardiology on call. I'm going to do a heart case tomorrow. That'll be case of the day. I'll post that, midday tomorrow. And then he will come in live with me, and then we'll discuss. The other thing that I want to start entertaining is I want you guys all to come live with me every once in a while, and I want you to ask me questions, and let's just go over medicine or just shoot the shit, whatever you want to do. So I'll start entertaining that too soon. All right. Coolest IG live to date, dude. Oh, thank you so much. Not dude, ma'am. Sorry. I appreciate that. What kind of seminar? I should do a seminar. I do talks all the time. I do monthly talks to the medicine residents here. I'm going to be going and doing IR and radiology talks soon. Miss. Frankie Jean. I kind of see the little picture now. All right. I do some talks. I love it. I absolutely love it. Tomorrow, though, I think I posted last week. Should I try an open mic night? I'm going to open mic tomorrow. I don't think I'm gonna actually do some jokes, but I'm gonna check it out. First time I've been here in the city, so I'm gonna see what it's all about. Apparently, you got 3 minutes to do whatever you can. So maybe the next week after that. IR is the best. Yes. I'm going to do some more IR stuff, and I'm going to have it relate to everyday medicine. I don't want to, if you want to, I will definitely get bogged down in the details because I love IR. But I want to do a lot of stuff that's related to med school, intern year, residency, whatever specialty you're in. That's what I'm all about. I don't want to be the guy who just kind of, does my thing and only talks about IR, that kind of stuff. No. All right, there we go. Frankie Jean, Miss Frankie Jean, does echo. Looking forward to tomorrow. Oh, you could probably teach the echo. Come on. All right. Are you guys good? I feel so much better starting doing these lives again. Vacation was good though. I can't complain. I appreciate you guys. We went through some good stuff today. Once again, I'm gonna try to get cardiology on call tomorrow. We'll do a joint live. We'll do a heart case. Go seriously to my YouTube page. If anything, go to the chest X-ray lecture and just memorize the hell out of that thing. I promise you, it will get you out of a bind. All right, guys. Oh, real quick, I'm a new follower. Have you done a video on bone fractures and different types? Nice. Good segue because I did talk about doing collabs with other people. I'm going to be doing a collaboration with somebody on that as well. So that's coming in the works. All right, guys. I appreciate y'all. Until next time, I'm about to go juice. Later. Like, not juice, but yeah. All right, guys. Later.